Thank you all for coming to the Northwestern CME Nephrolithiasis course. This is broadcast live now, but it will be up on the website for re-review for anyone who wants to get CME credit related to stone disease. I'm really excited to announce our lecturer this evening, Dr. Sara Best. I consider her a friend. We actually went shark diving in South Africa together many years ago, so I know her very well. She is the associate professor at University of Wisconsin in Madison. She did her minimally invasive fellowship in stone disease and laparoscopy at UT Southwestern with Dr. Pearl and Dr. Kadedu. She has extensively researched stone disease and has over 100 publications in the area of nephrolithiasis and renal tumors, and has even authored a Campbell's chapter. She also is quite passionate for education and has participated in multiple AUA courses as course director and faculty, as well as endourology courses. And she has previously been the co-director of the residency program at Madison. Currently, in addition to all of the stuff she's doing, she is also the medical director of Litholink here in Chicago, which is, as most of you know, is a great 24-hour urine metabolic, stone metabolic urine company that's been around for years and is of excellent quality. So she's taken over that role as medical director, and it's just a great honor to have someone as well known and as educated in stone disease giving us a lecture on stones today. So thank you, Sara.
Thank you. What Dr. Krambeck doesn't say is that she set a very poor example in the shark diving realm, because she kept getting yelled at by the people with the company, like yelling at her to stop trying to touch the sharks, like these massive great white sharks. And Dr. Krambeck just was unable to resist trying to touch the sharks. So when you swim with sharks, you gotta be prepared. And I don't know anybody who's more prepared to swim with sharks than Amy Krambeck. So thank you for the kind introduction. So in the next few minutes here, my goal is to try to show you a practical approach to the management of kidney stones. I think this is one of those topics that people tend to find really daunting. Like it's too complicated, they can't figure it out, it's drugs outside what we are usually used to prescribing, like alpha blockers, etc. And my goal is to hopefully persuade people that this isn't that hard and it can make a huge difference. It's not so much to learn, it's really if you can master a couple of drugs, an alkali agent like potassium citrate or a thiazide, you're most of the way there. A few diet recommendations that are generally pretty common sense and also in line with your patient's other health goals are ones that you can push. And finally, it's effective. Those who are given calcium stone formers who are given potassium citrate experience 80% remission with long-term therapy. And similarly, thiazide stone formation rates on patients who are given the drug went from almost 3 stones a year to practically 0 within the course of therapy. So that's a huge deal and a significant diminishment of suffering. So I think it's worth learning. As Dr. Krambeck alluded to, I do have an important conflict of interest to disclose here, and that is that I worked for LabCorp, blogging, researching, helping people out with the 24-hour urine test that we do there, now called the Litholink test. That used to be the name of the company, but we are a part of LabCorp. So while I have forever been a big believer in a 24-hour urine collection, you really asking me if you should get a 24-hour urine is kind of like asking the barber if you need a haircut. So do take it with that a grain of salt, but hopefully I have the evidence to back up what I say. In the next few minutes, we're going to talk briefly about the epidemiology and pathogenesis of stones, and then spend most of our time talking about and reviewing the guidelines on the pathogenesis and treatment of the 3 most common types of stones, the various calcium stones, uric acid stones, and then a few words on the follow-up of stone formers. What I'm not going to talk about today, however, is infection stones and cystine stones, because those are really different in a lot of ways, and I think outside the scope of what we have time for today. So in terms of the epidemiology of stones, those of us who've chosen to make our career in this realm are doing okay for job security because the rate of stones is growing up in a linear fashion. The latest longitudinal studies, such as NHANES, suggest is actually up to about 10% of Americans being afflicted with stones. And while we traditionally taught that men were far more likely to be affected by stones than women, this gap is really narrowing, probably due to increased rates of obesity. And then finally, white Americans are most affected by stone disease, but similarly, with rates of obesity, we can begin to see this in other cultures and folks of different backgrounds. The pathogenesis of stone formation on a chemical level is really driven by supersaturation of the urine. And I'm sure everybody remembers at some point in junior high chemistry, you had to do an experiment where they gave you water and told you to keep putting in sugar until you couldn't get any more to dissolve in the water. And then that was the point at which the water was supersaturated in terms of sugar. It's the same thing for the various salts that form kidney stones, such as calcium oxalates and all of the other ones. If they are super saturated in the urine, they can crystallize out. And this is a process starting as crystal nucleation. Once those crystals become bigger, they can aggregate together. And once they weigh enough, they can be retained within the kidney rather than flushed out easily in the urine, and then a stone can form. Thankfully, there are a variety of stone inhibitors that we actually don't have the ability to easily measure that raise the level of supersaturated needed for crystal growth. So this is something you may see on tests like the TAM horsefall protein, which is the most abundant protein in urine, helps reduce the risk of stone formation, but also things like nephrocalcin, uroponin, and various glycosaminoglycans are stone inhibitors, thankfully. The majority of my talk today is based on stuff that comes out of the AUA guidelines for medical management, which first came out in 2014 and then were validated in 2019. And the panel who's currently just started to revise them is a secret very closely kept, but I am sure that we'll see some really exciting updates, especially with some new innovations that we have seen, some of which I'll talk about. So the first part of what we should talk about is how should you even evaluate a stone former? So just like any condition that you treat as a doctor, your management starts with a good history. And then you want to get pertinent labs and pertinent imaging as we're surgeons. And then your job as a urologist is to determine, is this person at high or low risk of future stone formation? And the AUA actually spells this out, and they define people are low risk if they are of all of these things. So they're a first-time stone former who has no family history or any of these other concurrent medical conditions that would raise their risk of making more stones. Similarly, high risk then are people who are recurrent stone formers or anybody who presents for the first time, but they have more than one stone on their initial presentation. So a CT that shows 2 stones and maybe just one of them is the ureteral stone that brought them to the ER. Any pediatric patient is a high-risk stone former, both because they have a lot longer to experience recurrence and also because some of the metabolic conditions and diseases can affect them at a higher rate. Folks with a solitary kidney are high risk by nature of the fact that if a stone blocks their solitary ureter, they can go into renal failure. And then we're going to talk about all of these conditions really over the course of today. But anybody who has any of these issues in their history is considered high risk as well. So not surprisingly, a lot of our stone formers are technically high risk. People who are low risk, according to the AUA guidelines, undergo what's called the screening evaluation, while those who are high risk undergo the metabolic evaluation, and we'll review those. The screening evaluation really consists of a good history, looking for the family history, a good dietary history, some of which we'll talk about, and then those conditions such as GI disease, bone disease, gout, diabetes, metabolic syndrome, and obesity, and recurrent urinary tract infections. And then you get a relatively limited data set to help you evaluate these patients. So the serum labs that you want to get are a basic metabolic panel or chemistry, and that's going to help you know if there's a metabolic condition going on, electrolyte abnormalities or an acidosis, give you a clue about their overall renal function. Then you also want to obtain a calcium, uric acid, and if primary hyperparathyroidism is suspected, you should get a parathyroid hormone level. And it's important, many of us will order both the calcium and the PTH at the same time, because something I certainly didn't know early on in my stone career, or even maybe as an attending, was that you have to order the calcium and the PTH at the same time because they both have some diurnal variation that isn't perfectly timed with each other. And so you don't know how to interpret one necessarily without the other. Screening evaluation, so low-risk patients should also undergo a urinalysis. You can get a few clues off of that. First of all, if you see any crystals that might be able to tell you what type of stones the patient has. You can also get the pH of the urine. If they have acidic urine, they might be making uric acid stones. If they have a very high urine pH, they might be forming infection struvite stones. And similarly, urine culture will help you detect if they have urea splitting bacteria, which I guess that is out of the scope of this talk, but that could help you know also what type of stone you might be dealing with. So we talked a bit about these important items from the medical history. GI disease, we're going to talk about why that puts people at higher risk, but gout is associated with hyperuricemia, which we'll talk about uric acid issues. Bone disease can result in bone breakdown and hypercalcemia or hypercalciuria, depending on the etiology. Type 2 diabetes and metabolic syndrome cause issues with creating an acidic urine that we'll talk about due to ammoniogenesis defects, recurrent UTIs for struvite stones, renal tubular acidosis, primary hyperparathyroidism, and sarcoidosis, both because of hypercalcemia. We also want to review any medications or supplements the patient is taking. We have to specifically ask about supplements because patients don't always think that we care or that they're pertinent. And they might be taking a vast amount of vitamin C every day. That was a huge thing during the pandemic when there were some rumors that that would reduce your chances of COVID. But it's important to ask about these medications as they can be associated with stone formation. So again, here's that screening evaluation. If you have a low risk patient and all those things are true, you're assessing that, you're going to do a screening evaluation. And once that is indeed low risk, you can make empiric recommendations to the patient without getting a 24-hour urine collection. You can recommend that they drink at least 100 ounces of fluid daily and follow a low sodium, low animal protein diet and consume the RDA's recommended amount of calcium, a normal amount of calcium in their diet every day. Now, on the other hand, if your risk assessment reveals that this is a high risk person, they instead should undergo the metabolic evaluation, which sounds all fancy, but in fact, what it is just the screening evaluation plus a 24-hour urine collection. So they get the same history, blood work, and the urinalysis, but then they should also get a 24-hour urine collection to evaluate their risks. And we're going to spend the majority of our talk today talking about those various risk factors and what to do about them. So we'll start with the most common type of stones, which are calcium stones. 70 to 80% of stones are one form or the other of calcium oxalate, while 15% are calcium phosphates. And so all the other types of stones are substantially less common. So I always joke with my residents when I am trying to have them tell me, I'll say, what type of stone do you think this is during your uteroscopy? And I'll tell them, well, if you just say calcium oxalate, you're going to be right just by virtue of the frequency, more than half the time. So, so these are the most common stones that we see. And we can't talk about calcium stones without talking about hypercalciuria or elevated urine calcium levels, because this is a significant common risk factor. Hypercalciuria comes in 3 different kinds, which are somewhat confusingly named absorptive, renal leak, and resorptive, which is the old word for primary hyperparathyroidism, which I mentioned because you can still see that sometimes in some of the old classic papers. So each of these can cause hypercalciuria, but it's by a different mechanism. So absorptive, as this little picture alludes to, is where your gut is overly efficient at absorbing calcium from the foods and drinks you consume. And so you have more calcium absorbed. That means that you get more calcium into your bloodstream. That's very tightly regulated. And so to get rid of that extra calcium, your body has to excrete it in your urine. So that's absorptive, the most common. Second most common is renal leak hypercalciuria, which, just as it sounds, is where the kidney has a defect where it is not reabsorbing 98% of the filtered calcium like it's supposed to. It's got a defect in it where the body is constantly leaking calcium out into the urine. Which, as we'll talk about, is a big deal because our our serum calcium levels are extremely tightly regulated, and your body will sacrifice nearly anything in order to maintain that. And then finally, primary hyperparathyroidism is different from either one of these, even though it also causes hypercalciuria in some patients, and it's typically caused by the overproduction of PTH hormone from typically one, but sometimes more of the four parathyroid glands. So all of these can cause urinary hypercalciuria, but only renal leak and primary hyperparathyroidism cause an elevation in PTH hormone. And the reason that you should care about that is because this is your chance to be a hero as a urologist and cure other disease, because having hyperparathyroidism causes bone resorption. So one of the effects of PTH is that it is going to break down your bones in an effort to release more calcium into your bloodstream to maintain calcium, serum calcium homeostasis. In primary hyperparathyroidism, that's the underlying defect, is that actual production of PTH. But in renal leak, that's how your body is trying to compensate for the fact that you're constantly wasting calcium. You're not able to maintain a normal blood calcium level without freeing up some from your bones. And just like it sounds like, breaking down your bones to maintain your serum calcium level is dangerous potentially. These patients can have osteopenia and osteoporosis and be more prone to fractures. So you can save the day if you identify that a patient has either primary or secondary hyperparathyroidism and hypercalciuria, and you take steps to address it. So this is a complicated table that is saying essentially the same thing. But my whole point of showing that is that really our metabolic workup is here to help us quickly and easily figure out if this is present. So we're supposed to check a serum calcium and PTH. And if they're high, if the PTH is high, you can tell if it's renal leak or primary hyperpara because the calcium is going to be high in primary hyperpara, whereas it'll be normal in renal leak, and it's a secondary effect. So our job really as urologists is only to find the primary hyperparathyroid patients because they're treated very differently with surgery and referral to endocrine, whereas the other two types of hypercalciuria, as we'll talk about, can be treated effectively with thiazides. So you don't technically need to figure out which the patient has. Anytime we talk about hypercalciuria, it's really important that we also talk about the role of sodium because oral sodium intake is a major determinant of renal calcium excretion. And in fact, there's a linear relationship between these two that we can actually demonstrate with a example case here. So for every increase in sodium of 100 milliequivalents per day in your diet, this is going to increase your urine calcium by 50 milligrams a day. I always make it clear to my patients that your body needs so little sodium to do its daily processes. Really, any sodium that shows up in our urine is coming from items that were food and drinks, medications, whatever that we're taking in. And you can't be peeing more sodium than you are taking in over the long term, or you will shrivel up and die. So it really is your diet to blame for this. But so for this example, let's say you had a woman with mild hypercalciuria, 230 milligrams per day, and you jump your eyes over, as I tell my residents, to the urine calcium is the urine sodium is 300 milliequivalents per day, so pretty elevated. If you advise that patient to drop their dietary sodium and they get it down even just 100 milliequivalents per day, 200 is still pretty high. you would expect, thanks to that mathematical relationship, a 50-point drop in their urine calcium. So in this patient with mild hypercalciuria, with diet change alone, they could be able to normalize their urine calcium. So that's an important approach for many of our patients. The other kicker, though, is that even if the patient has significant hypercalciuria and you can only blame part of it on the sodium and you're going to give them a thiazide anyways, unfortunately, unless they also reduce their dietary sodium, the medications don't work well. They actually block the hypocalciuric action of the thiazides. So they kind of have to do both. So thiazides are the mainstay of treatment for hypercalciuria. And as mentioned, it can be used for both absorptive or GI hypercalciuria and renal leak hypercalciuria. And the way that this works is by augmenting the calcium reabsorption in the distal tubule. So in renal leak hypercalciuria, it's like a perfect treatment because it actually corrects the actual defect where the nephron is leaking excess calcium and it causes it to reabsorb it. So it's a great treatment. But in absorptive hypercalciuria, again, that's where your gut is overly efficient at absorbing calcium. It compensates for it. So it takes all that extra filtered load of calcium, brings it back out of your urine, and then has it put into your bones where it's not in your bloodstream and it's not in your urine. So there are multiple medications that can be used to have a thiazide-like effect. There's hydrochlorothiazide, which unfortunately has a relatively short half-life and is therefore a twice-a-day drug. But indapamide and chlorthalidone, while not true thiazides, have a thiazide-like action in terms of hypocalciuria, and they're once-a-day medications. And all of these can work great. And I think which one each of us uses tends to depend on where we did our training. I am a chlorthalidone person because that's what Peggy Pro uses. So that's what I'm most familiar with, but any of them work great. I will mention amiloride hydrochlorothiazide is another option where it's hydrochlorothiazide plus a potassium-sparing diuretic so that patients don't necessarily have to worry about taking a potassium supplement. Like all medications, thiazides can have some side effects that we need to be aware of. Namely, hypokalemia is a big one, so it's important to check a potassium within a week or two of starting or changing a dose of a thiazide. And we often will give a supplement of potassium for patients we prescribe thiazides. These drugs can also cause hypocitraturia, which is not great in the long term because we don't want to trade one risk factor, hypercalciuria, for hypocitraturia necessarily. Similarly, hyperuricasuria and hyperglycemia require monitoring as well. We will often treat both the hypokalemia and hypocitraturia with one combination co-prescription of giving patients potassium citrate. So typically, if I give somebody chlorthalidone to start, I'm going to be at least talking to them about starting a potassium citrate supplementation at the same time in order to address both of those issues. Now, for years, I was able to talk about thiazides in my stone prevention talks, and really nobody would ever have any questions about it or anything. But now that's all changed since the last year because of the New England Journal article published by a group out of Switzerland, a group out of Switzerland who performed a prospective randomized control trial where they randomized 416 calcium stone formers to either be in a placebo arm or one of 3 hydrochlorothiazide drug levels prescribed once daily. The primary endpoint of this study, which we're going to talk about, was symptomatic recurrence. So either passage of a stone or recovery of a stone or a ureteral stone event, ER visit, or needing to undergo surgery for a stone starting anytime 6 weeks after starting the trial, which is important to know because a lot of these patients started with having pre-existing stones. And using this primary endpoint, certainly what the abstract reads as and what all the headlines, this really got taken up by both the lay and medical media. And the headline was, thiazides don't work for kidney stone prevention. And in terms of their primary endpoint as they found no difference in symptomatic recurrence at a median of nearly 3 years. But in the next minute or so, I'd like to tell you why take a closer look at this study and why, how I've used this data to change my practice or not. So firstly, I'd point out a few issues. So their primary endpoint of symptomatic recurrence. So we all know who take care of patients with kidney stones, when a patient can have a stone for years and it can just suddenly decide one day to drop into the ureter. And that doesn't really have anything to do with whether you put them on a medication or if it's Tuesday or any of those things. It's seemingly random as far as we know. And so I wouldn't tell somebody, or I wouldn't think that my treatment had failed somebody if they went to the ER passing a stone 6 weeks after starting a hydrochlorothiazide, especially if they had a stone beforehand. They probably didn't form a brand new stone while on the thiazide within 6 weeks in any of those arms. So I don't think that's a very good endpoint for us to use. However, that was their primary endpoint. However, they did have a secondary endpoint, which I think makes a ton more sense, and that was radiographic recurrence, which is growth of existing or development of new stones compared to a baseline CT, which all the patients had. And that makes a ton more sense to me. If you're trying to figure out whether somebody is actively growing stones, you don't want to know if they suddenly dropped their 8-year-old stone into their ureter and had to go to the ER. You want to know, are their stones getting bigger? Are they making new ones? And if you have patients with CTs, it only makes sense to me that this is a better measure of whether your intervention is working. And so this information is available if you go into their online supplementary material, and you can see actually that there was a difference between the amount of radiologic stone recurrence between groups. So folks in the placebo group, about half of them experienced increase in stone size or new stone size on CT over the course of the 3 years. However, those in the 2 larger doses of hydrochlorothiazide, only about a third of them experienced growth in stones. And so I would say of the more reasonable or measure of outcome, that makes more sense to me, and it seems like it is working. So in fact, it was a 46% reduction in stone growth at the 50 milligram dose compared to placebo. And then finally, whenever we're trying to evaluate, take a look at an article, we want to look, does the mechanism make sense? And so we think that thiazides reduce stone risk by reducing urine calcium. So if you did a study and you don't see an effect on urine calcium, then it doesn't really make sense that that would work. But in fact, they did. Again, it was not one of their primary or secondary endpoints, but again, if you dig into their supplementary data, you can actually see that while the folks in the placebo arm had an increase in their urine calcium over the 3 years, the folks in all of the thiazide doses, but especially in the highest dose, experienced a significant drop with therapy, a 50-point drop milligrams per day in the folks on the highest dose of thiazide. So it makes sense that it's having the effect and that we would expect that that would reduce stone formation. So my biggest problem, though, with this study, unfortunately, is in the study design. So I already mentioned I don't like their primary endpoint, but overall, for reasons I don't understand, they completely underdosed their intervention. I already told you that hydrochlorothiazide has a short half-life and really has to be dosed twice a day in order to maintain decent drug levels for efficacy throughout the 24-hour period. And they, for some reason, chose to only give it to anybody once a day. So that means that nobody had a high level of drug in their system throughout the day. And on top of it, the starting dose for stone formers is 25 milligrams twice a day. So 3 out of 4 arms were woefully underdosed in this study. And I'm not sure why they did that. They could have used indapamide or chlorthalidone if they wanted to prescribe once a day. I don't know why they did that, but they did. But I think it really affects how we can interpret the results of their data. But that being said, in summary of what I think about this article, unfortunately, the intervention was woefully underdosed. Secondly, their primary endpoint, the one that is the abstract, that was all the headlines and what everybody's take-home message, I think was a tragic disservice to thiazides because their primary endpoint doesn't really make sense as what to measure, whereas their secondary endpoint, radiographic recurrence, or proving that stones increase or not. So secondary endpoint really did show a reduction in the stone growth. And then finally, the urine calcium levels did significantly go down in folks on the 50 milligram dose compared to placebo. So I personally continue to recommend thiazides to my stone patients. And I think that this data actually is more in support of it if you actually dig into the actual supplementary data. So I'll get off my soapbox. Happy to talk about that more at the end if people have questions, but let's talk about hyperoxyuria. So hyperoxyuria can also come from one of three general mechanisms. The first is primary hyperoxyuria, which is a genetic underlying condition that's a disorder of the endogenous biosynthesis in the liver. Then you can also end up with hyperoxyuria from dietary overconsumption of oxalate or its precursors, or underconsumption of calcium, which we'll talk about. Or finally, from bowel disease, you can get enteric hyperoxyuria. We'll talk about each of these. So first, primary hyperoxyuria, as I mentioned, is a congenital hepatic enzyme deficiency. And there's actually been 3 types now described, all of which there are genetic tests for that are commercially available in genetics panels. Type 1, PH1, is the most common, affecting 80%, and is generally the most severe. Classically, this was a really, sad and horrific condition for a lot of children with this condition, in that 50% of them were often in renal failure by the time they were 15. And that's a really hard life to live. However, it was still a medical perplexing condition because even 21% of them may not present until adulthood with just the occasional stone, but indeed they are PH patients. So that essentially used to be the end of my commentary on primary hyperoxyuria until 2021. I would just say, well, these folks needed a combined liver and kidney transplant as the only therapy really available. But now in 2021, there was really a revolution in stone therapy for albeit a small number of patients with primary hyperoxyuria, and that's these new RNA interference agents, lumasiran and nedosiran, which are a new class of medications. Lumasiran is FDA approved and commercially available, and it targets glycolate oxidase. And the study trials for this showed that 65% of patients with PH who were given this had a normalization or near normalization of their urine oxalate levels. And, these people can have urine oxalates 100, 200, things like that, very, very high, that's landing them in renal failure. And so it's amazing that a sub-Q drug given once a month can resolve that. Nedosiran was approved just in October, but will be commercially available soon, is the information that I can find. This works a little differently. It targets the mRNA encoding hepatic lactate dehydrogenase A, but it too results in the trials show that 50% of patients can achieve normal or near normal urine oxalate. So I think we're going to find out a lot more information about the management of these patients, and hopefully this is going to be amazing for the people who are affected. However, most of the people that you see in your practice with hyperoxyuria are not going to have PH. They're going to have either dietary hyperoxyuria or enteric hyperoxyuria. So you would get oxalate in your urine from one of 2 ways. One is that your liver makes it. So even if you consumed nothing, you would still have some oxalate in your urine. But then the other source is from things that we take in. So classically, we taught people that hyperoxyuria comes from oxalate-rich foods like spinach and that sort of thing. But I would argue to think honestly about your stone-forming population. I don't know about Chicago necessarily, but here in Wisconsin, I don't see a ton of my stone formers who I think have spinach saladed themselves into stones. I don't think that that's it's not my smoothie consuming folks who are generally, my biggest stone formers. I think it's important to check for those kinds of crazy, weird consumptions, but I don't think spending a ton of time telling somebody who eats, one spinach salad a year that they need to fix their stones by, following a low oxalate diet. I don't think that's particularly helpful. I do see a lot of folks, even being from the dairy state, who I think have hyperoxaluria because they are not consuming enough calcium-containing foods at meals, which is something we'll talk about a little bit more shortly. But I do recommend that, both for bone health and for hyperoxaluria. And the other reason I'm not super gung-ho on, always telling everybody they have to follow a low oxalate diet is that, from my mentor, Dr. Chris Peniston, who is amazing and is a PhD nutritionist who is the world's expert in diet and kidney stones, and she sees patients with us in Wisconsin. And she points out that a lot of high oxalate foods are actually really healthy in lots of other ways. And ways that can make them good for stone formers. So foods that are high in fiber, phytate, the various bicarbonate precursors, magnesium, all of those things may actually cancel out some of the effect of that oxalate and reduce the overall quality of somebody's diet if you restrict it. And in fact, she actually did a prospective study where she put some patients with hyperoxaluria on a low oxalate diet alone, and some put on calcium citrate with the lunch and dinner. And she found that generally both groups were able to get their urine oxalate levels substantially lower with either approach. Here too is just another slide summarizing some of these foods that are high oxalate, but showing all of these other things that are good for us and good for our stone formers. They might not be able to get in their diet if you tell them they can't eat anything with oxalate. So enteric hyperoxaluria is another condition that we'll see a lot of as urologists, and it's really anything with fast GI transit or chronic diarrhea. And I like to make a plug for, I think you all need to start asking your patients, not just do you have diarrhea, but asking them how many bowel movements they have per day, because people's own normal is what they're used to. And so they may not even think of it as diarrhea. But important to ask about, because any condition of chronic diarrhea, be it from an IBD or small bowel resection or gastric bypass surgery, all can lead to this issue, which is where they get fat malabsorption. And the excess free fatty acids that are then floating in the gut lumen are negatively charged, and they are chemically looking to bind with something that's positively charged, which is the cations in the stool, the calcium and magnesium. And so all of the fat is then binding up that calcium. That's called saponification. And that means that there's less of those cations to bind with the also negatively charged oxalate. And free oxalate is really easily absorbed through the gut lumen, whereas calcium oxalate, if it forms and crystallizes, molecularizes in the gut lumen, that usually goes out in the stool. So, diarrhea and frequent loose stools can cause stone risk factors, both for this hyperoxaluria, but also because they may have a low urine output because they're losing all their fluids from their stool. They can have metabolic acidosis and hypocitraturia, as well as hypomagnesuria. So it's really important to identify those folks. I will be really interested to see how bariatric surgery goes in terms of with all the new weight loss agents coming out on the marketplace. But this is certainly important to folks who've had bariatric surgery, because they can get significant hyperoxaluria. In fact, jejunal ileal bypass, which was one of the early forms of bariatric surgery, actually caused urine oxalate levels like pH in the hundreds, and it caused renal failure and actually led to that type of surgery being banned. And so the newer forms like Roux-en-Y gastric bypass have lower but still pretty darn significant oxalate levels in a lot of our patients. And so it's important to be aware of these. Brian Matlaga did a great study looking at patients who had undergone gastric bypass, comparing them to patients with obesity who are also at higher risk for stones but hadn't had surgery. And he found that folks with the bypass surgery were nearly twice as likely to receive a diagnosis of stones and more than 3 times as likely to undergo surgical therapy for stones. So it's important. All right, so shifting gears again, what are we doing time-wise? Pretty good. So hypocitraturia. So the other things that we've talked about so far We have been talking about hyperoxyuria, hypercalciuria, but citrate is actually protective. So we want a higher level in the urine, and that's because it chelates or binds calcium ions, as well as is an inhibitor of crystal nucleation. So we want high citrate, but there are a lot of conditions, especially metabolic acidoses, that can cause, due to a systemic acidosis, can cause urine citrate levels to be low. This can happen in chronic diarrhea, but also RTA, renal tubular acidosis, is the classic one, certainly something to know for tests. Distal RTA, or type 1, is the type associated with stone formation, and these patients are unable to excrete acid in their urine, so they're unable to excrete protons. Protons or acid are what makes urine pH lower or more acid. So our body actually has two ways of excreting some of the acid load of metabolism. We can either excrete it as ammonia, or we can excrete it as pH or protons, so an acid. So some people will drop their pH in response to an acid load. Some people will increase their ammonia, and some people will do both. But people with distal RTA can't drop their urine pH in response to an acid load. So their urine pH is high, and they can get a metabolic acidosis. And I remember this because I can remember the ileoconduit metabolic abnormality. It's a hypokalemic, hyperchloremic metabolic acidosis. So for testing purposes. So RTA is one cause of low citrate. We can also see it in patients with thiazides or who are on carbonic anhydrase inhibitors or unknown. So how do we treat hypocitraturia? Well, we start with dietary therapies. Lemon and orange juice have been done in studies to give people beverages to replete citrate effectively. I also tell patients, in general, if you can shift your diet towards a more vegetarian style diet, it's rare to see a vegetarian who doesn't have an alkaline urine, so and have a nice citrate level. So those are good underlying dietary changes. But if that's insufficient, we do have a variety of alkalinizing agents. The most common is potassium citrate, which is typically prescribed as a slow release tab. And we have to give it 2 to 3 times a day. Despite being slow release, it can cause stomach upset, and we have to be cautious of giving any potassium supplement to patients with significant renal insufficiency. Also important to know, some patients with fast GI transit, if they have GI malabsorption, they don't have time to leach all of that medication out of those slow release tablets. So they are better given the liquid formulation, polycitric A. Another option that is becoming increasingly popular is sodium citrate or sodium bicarbonate, which is the stuff in the orange box. I actually use a lot of this, again, partially because of Chris Pennison being my mentor, but I have a lot of patients who can't afford potassium citrate prescriptions or hate taking the massive pills. It is, for $1, you can buy like a year's worth of orange boxes to take a good alkali substitute as well. Also important to point out, alkali therapy also raises urine pH. So that's both potassium citrate and sodium bicarbonate. Both will increase urine pH. And that's helpful for a lot of our patients who may also have acidic urine as an independent risk factor. But it's important to know that we need to be cautious of that in some folks to not tip them over into forming calcium phosphate stones. However, I think it's important to point out that in patients with renal tubular acidosis, these patients have a metabolic acidosis, maybe breaking down their bones, maybe sick from metabolic acidosis, and you correct that by providing them alkali, often with potassium citrate as at least part of that. And Dr. Perminger did a small but classic study studying 9 incomplete RTA patients. And they found that even though their pH went up in their urine, they formed fewer stones on potassium citrate. Another shout out for alternative alkalis. I think 10 years ago we saw very few papers about this or people talking about this, but this is all the rage. There's a lot of various commercially available over the counter additives that you can buy, some of which are developed by colleagues of ours, that can be very effective at both increasing citrate and pH, or baking soda, for example. And so folks did an excellent study looking at using alternative alkali and found that just like with potassium citrate, they were able to see both an increase in urine pH and citrate, and neither group experienced an increase in urine calcium. The dose that I typically start patients on for sodium bicarbonate is a 1/4 teaspoon of that powder twice a day, however they can get it in. So I have heard that mixing it in orange juice and waiting for the foaming to subside is amongst the most palatable ways, but you don't want them to drink a whole lot of that because that's a lot of calories. All right, we're getting there. So hyperuricasuria is our next risk factor. So elevated urinary uric acid. So whenever I say that, a lot of people are like, oh, we're going to talk about uric acid stones. But no, that's not what we're talking about. Uric acid stones are caused by low urine pH. We're going to talk a little bit more about that. Low urine pH you treat with alkali, or potassium citrate. That's not what we're talking about. We care about elevated urinary uric acid mainly because it increases calcium oxalate formation or stone formation. So it that same analogy about a grain of sand inside an oyster, heterogeneous nucleation can form where the grain of sand is uric acid crystals and then a calcium oxalate pearl forms around it. So how do we treat hyperuricasuria? Again, we start with dietary interventions. This can be tough, especially in our farming communities. They have access to a lot of amazing, well-raised beef and poultry, and that can be a major source of purine. So dietary animal protein is the phrase that we use. Chris Peniston says flesh foods or anything with a face, both of which make me sort of uncomfortable, but that's to point out it's not just red meat. Fish is actually very high in purines, gram for gram. But restricting those in our diets, cutting down the number of times per week it's consumed and the portion size can be critical. But also know it does not, that dairy and eggs are not high in purines, so those don't have to be restricted for hyperuricasuria. The follow-up treatment, if diet is unsuccessful, you can alkalinize the urine because that improves the solubility of the uric acid, or allopurinol can be used if patients have a very high level of hyperuricasuria, especially if they also have gout or hyperuricemia. But your first line treatment is typically going to be dietary and alkalinization. So uric acid stones should get a shout out here. The etiology of uric acid stones, as I already mentioned, is from almost always from low urine pH. Most uric acid stone formers, if you look at their 24-hour urine, they have a normal urinary uric acid. It's that their urine is so acidic that the uric acid crystallizes out, even if they don't have a ton of it. The most common causes of low urine pH in American populations are folks with metabolic syndrome or type 2 diabetes because they have inability to excrete acid as ammonia that's impaired. So our underlying treatment for our mainstay of treatment for uric acid stones is urinary alkalinization. I actually love seeing folks with uric acid stones because I can dissolve often stones that they have if they're not obstructing with alkalinization over the course of months. So that they can avoid surgery or stone passage. But I also feel comfortable telling people, hey, if you have uric acid stones and you're able to consistently get your urine pH above 6 or so, I think you'll never make another uric acid stone. And we can do that with baking soda or potassium citrate. It's rare to use allopurinol because these folks, again, that giving them allopurinol won't adjust the urine pH. And you can dissolve just a ton. This graph is Peggy Pearl's favorite graph. And it shows you can dissolve a ton of uric acid as long as your urine pH is 6 or higher. So that's why you do that rather than necessarily completely focusing on the production of it with allopurinol. So we're at the end here. Guidelines, the follow-up, the guidelines, AUA guidelines recommend that the follow-up consists of repeating a 24-hour urine within 6 months of really any change in therapy, whether you start dietary therapy or medical therapy, in order to assess response. And that, makes sense. If you're going to make a big change in your lifestyle or you're going to take a pill every day, you probably want to make sure that you're getting the effect and that you've made the right changes, or that it's having the effect that you want. And then the guidelines say you should consider repeating annually or more frequently, depending on what you're looking to see. It's important to obtain labs indicated to assess for the adverse effects of pharmacotherapy. So hypokalemia from the thiazides, for example, important to check for. The guidelines also suggest getting a repeat stone analysis whenever available, because changes in stone composition can occur as risk factors change. And that's something I'm really excited to hopefully be able to study soon with Litholink. We have over 600,000 stones, and I'm really curious to delve into what number of people have experienced a change in their stone type over time. And then finally, the guidelines recommend periodically obtaining repeat imaging to assess for recurrence. So in summary, hopefully I've convinced you that you really can be a hero here and a great doctor by being a good stone doctor. So you can find important medical conditions, conditions of hypercalcemia, distal RTA or GI disease, things that can make people really sick, not just kidney stones. But you really, if you only learn how to prescribe potassium citrate, you can actually treat multiple conditions or stone risk with just that. So it actually is probably efficacious for some types of hypercalciuria. It improves urine citrate as well as pH. But then if you get to know a thiazide, I think, as I've hopefully convinced you, that I think that these drugs are really efficacious. Don't forget to recheck the potassium. And you can use, even if you don't feel comfortable ordering a 24-hour urine. Let's say you're in a place where you don't have easy access to one, or you have patients who just keep forming stones, but they always have a reason why they haven't done the 24-hour urine. There is good data saying that you can prescribe either of these treatments and be right and helpful even without ever having done a 24-hour urine. So empiric therapy can be very effective. You get some bonus points if you identify any hyperoxyuria red flags, like the crazy juicers, and learn to use allopurinol for bad hyperuricasuria. But overall, this is a nicer time in Madison, Wisconsin, when we have our beautiful, I prefer the sailboats as opposed to the ice fisher people that you would see if you had a similar view right now. But hopefully, I think it's going to warm up both here and in Chicago. So I think we have a couple of minutes for questions.
Sara, that was a fantastic talk, and you really covered everything in a very short period of time, which I was impressed that you could cover all that. You briefly mentioned at the end about, empiric treatment with just potassium citrate or chlorthalidone if a patient is a stone former.
Yeah.
And when I was going through training with Lingaman, it was always, you don't give potassium citrate to calcium phosphate stone formers. You're not going to raise their pH. But then, as I went along further, once their pH is high, it's already high, right? And so driving it higher with potassium citrate is not really going to worsen their calcium phosphate stone disease once they get past the pKa. Is that right?
So sort of. So what it is that you don't know until you try. So some people respond to alkali by increasing their urine pH, and some people respond by increasing their citrate level. And it's hard to predict sometimes. So it's about 50-50 when John Asplin, my mentor at Litholink, looked at it. It's about half the time that you're going to get one or the other happening. And so you are going to have, I think it's about a third of patients where you're only going to really get an increase in pH with prescription of alkali. You're not going to get an increase in their citrate. So So really the thing is you have to check. So I think you get a follow-up 24-hour urine, and if you see their pH went way up, but their citrate hasn't hardly budged, then that's probably not a good treatment for them. And you should focus on something else, like, driving their calcium as low as possible, even if it isn't high, or something else like that. But it's hard to predict. So far as we know right now, some people doing one or the other. I hope that answers your question.
Yes, that was great. And then one other question is, with the diabetic patients, I find that if they're really poorly controlled diabetics, it's very difficult to raise their urinary pH.
Yeah.
And I mean, you can throw the whole book at them and they just won't budge.
Yeah.
Do you have any words of advice for those patients?
Yeah. Well, first, I will be very curious what happens with the GLP-1 agonist and the SGLT2 inhibitors, the obesity drugs. I think it's going to, some of the preliminary stuff, especially with the SGLT2 drugs, is that it can improve their metabolic urine profiles. So I think that'll be really interesting to see. But maybe we're going to see fewer people with poorly controlled diabetes if they can lose weight in addition, with taking that medication. So that's one thing. And then I think it's a multidisciplinary approach, right? So I think we don't want to give them advice contrary to what their other doctors are telling them. So we don't want to tell them, not to eat spinach salads. We want to be cautious about the protein issues, because sometimes their diabetes doctor is telling them to try Atkins or something like that, and we don't want to make it more confounding. So I think working in a multidisciplinary fashion is helpful. And then I think that these are folks that sometimes are going to need alkali from a variety of sources. So I may have people on potassium citrate and baking soda in an effort to try to get that pH to budge, especially if they're forming uric acid stones.
That's great advice. It looks like we have a couple of questions from the audience. Dr. Christensen, did you have a question?
Yeah, Sarah, thanks very much. I trained with Dr. Boyce, so this was something we did. We used to bring patients into the hospital for 3 days to do calcium loads and whatnot. So one of the things, I apologize if I missed this, I had to step away for a few seconds, but if you have calcium oxalate and hyperoxaluria, calcium oxalate stone former, and you had mentioned a lot of those patients just don't have a lot of calcium intake. Is there a role for calcium citrate?
Yeah, definitely. So let me see. How hard would it be to go back to that? Maybe it's too painful. So calcium citrate or dietary calcium in foods, if people can tolerate it, I think is a great idea. So I love using a nutritionist to get a baseline assessment of what somebody's daily dietary calcium intake is, to make sure, are they low or are they not low? And then getting them to time any calcium-rich foods that they do eat with their main meals. So, adding yogurt to lunch or dinner, or a glass of milk or something like that. And then certainly I do think that folks who just don't like calcium-rich foods or can't tolerate them, I think calcium citrate was designed as a stone-friendly calcium supplement. And timing that again with lunch and dinner, as those are typically the higher oxalate meals, I think can be really beneficial.
Yeah, and also I think it's inexpensive and easy to get compared to sometimes potassium citrate.
For sure.
If they're not on the
I don't think unfortunately, it doesn't provide a substantial enough citrate supplement. But I think in terms of the hyperoxaluria aspect, I think that it's an underused therapy for sure.
Cool, thanks.
Any more questions?
Fantastic. And I think we have another question from Dr. Perry Hsu.
Yeah, hi, Dr. Best. Great talk. I'm the fellow with Dr. Kramek right now, but and I did some my residency at UCI with Dr. Clayman, and we were really influenced by your use of baking soda. So we were having all our patients do a lot of baking soda there too. But my question is, if you have decided on starting a thiazide diuretic on a patient, and it turns out they have like significant side effects like dizziness or hypotension, do you have any strategies to help with their calcium, such as like changing dosing timing, etc.?
Yeah, so I will start folks, I will certainly back down the dose. If I started them, say, on 25 milligrams a day, or if sometimes people will tell me that my blood pressure runs low, or something about them makes me think that this might be an issue. I will sometimes start people on 12.5 milligrams of chlorthalidone, and then, see where they get with that in terms of their calcium response. And consider increasing it if they tolerate. I have also had some folks where one agent or another that maybe they can't tolerate chlorthalidone, but they can tolerate hydrochlorothiazide, or taking the amiloride hydrochlorothiazide combination pills, and tolerate that better. So I might try changing the mechanism, certainly trying to time it at night, I think for one of, can be a useful way as well. But the longer acting drugs are going to have a longer half-life as well. I don't know, Amy, do you have other things that you recommend in terms of trying to get somebody to be able to tolerate it?
No, I'm kind of like you. I mean, I'll cut the chlorthalidone down in half and see if that can give me a good effect. Try switching to indapamide, but some people just really can't tolerate it.
Yeah.
And then you have to go to other measures, like really get their volume up and, work on the pH and citrate and what have you.
Yeah, absolutely. Thankfully, relatively rare, the hypotension thing, but problematic for sure. Question.
I think Dr. Rashid had a question if he's still on the call. His hand was up for a minute and now I don't see it.
Thanks. My question was answered already. Thank you.
Okay, thanks. And let's see. Oh, Dr. Guo has a question.
Hi, Dr. Best. Thank you for your talk. I'm one of the urology residents. I was wondering if you could give us your opinion, and in your metabolic stone practice, do you use over-the-counter alkali citrate medications? And why is it that certain ones are over-the-counter, and why is like Urosit K prescription only?
Yeah. So the short answer is yes. I use a lot of baking soda as an alternative alkali. And I like it because it's cheap, generally well tolerated, and a small amount of material that someone has to consume. So, it's important if somebody tells you, oh, I found that potassium citrate on Amazon for so much cheaper, it's important I have them bring in or take a picture of whatever it is that they're buying, because sometimes the doses in there, the mill equivalents that they're getting, are so incredibly low that they'd have to take 20 pills a day to get the equivalent of what's in the prescription formulations of potassium citrate. I do think that some people really like the beverage options. The various ones that are out there, not to name names or anything of them, but you probably know what they are, but they, I think, can be really useful if somebody likes that, or is part of another, they're going to take some potassium citrate and some moonstone or something like that. I think using multiple things can be really helpful, and it's extra fluid typically that they're consuming. But I would say baking soda is my favorite alternate alkali that I use.
Well, I think we hit our time limit, and you can tell everybody's very interested in your talk and has a lot of questions, and I just really appreciate you taking the time to give us your words of wisdom and guide us on this subject. So thank you.
My pleasure. And anybody who wants to, feel free to email me if you have questions. I can give that to Mildred to send out to people. I am delighted to be asked questions. In fact, it's even more fun that I am now paid to take questions from our colleagues around the country. So It's one of my favorite things to do in my new job. So anytime, questions, call me. Thanks
All
for the
right,
invitation.
we'll take you up on that. You have a good evening, and thank you, everyone.
You too. Bye-bye.
Bye-bye.